Hello, I would like to start by thanking Chris Elias for the invitation to participate in this important and timely workshop on primary health care. Accelerated by the painful lessons from the pandemic, a global consensus has been emerging on the need to relaunch PHC so that it may better respond to the challenges and opportunities of the 21st century. It is interesting to note that the Alma Ata Declaration of 1978 was bounded by the 20th century, since its critical goal of health for all had an explicit temporal horizon by the year 2000. We are now almost a quarter of a century past that deadline, and we now know that the lofty aspiration has not been achieved. It is time to rethink PHC in light of the new realities of the 21st century. Salient among them are two areas of opportunity that may serve to counter the many challenges of this so far turbulent century. The first of those opportunities refers to the growing appreciation of the centrality of health to broader goals of sustainable development, global security, and human rights. The second area of opportunity derives from the current convergence of scientific and technological revolutions. My main message today is that we should leave behind the ideological debates which surrounded PHC in the past century and instead focus on developing primary care networks that are seamlessly integrated into the rest of the health system as its articulating element. The vision is to assure that services are provided on the basis of a defined population through proactive strategies, providing continuity of care, guaranteeing explicit entitlements, and assuring universal social protection in health. Since its origins in the Dawson Report of 1920, the concept of primary care as the first of three levels has been the subject of many debates and reformulations. We don't have time today to explicate them in detail, but this was the subject of a paper I published in The Lancet on the 30th anniversary of the Alma Ata Declaration with the title Reinventing Primary Health Care. Suffice it to say that among the many confusions surrounding this term, probably the most pernicious has been to equate primary with primitive care, which, not surprisingly, is mostly reserved for the poor. This reductionist perspective is not appropriate for the complex transformations that have taken place since Alma Ata in both health conditions and health systems. Let me briefly refer to each of these two dimensions. In contrast with the epidemiologic reality of developing nations in the 1970s, the day of simple priorities are gone. Problems only of the poor, like tuberculosis or malaria, are not the only problems of the poor anymore. Much has been written about the double burden of disease, which generates overlap between the unfinished agenda of infections, malnutrition, and reproductive health problems on the one hand, and the emerging challenges of non-communicable diseases and injury on the other. In today's complex world, we must add a third burden: the health risks directly associated with globalization, including the threat of pandemics and the health consequences of climate change. From the standpoint of health systems, the relevant distinction is no longer between communicable and non-communicable diseases, but rather between acute and chronic problems. There are more similarities in the way we deal with AIDS and diabetes than between AIDS and acute infection. Indeed, the epidemiological transition is associated with a change in the temporal nature of most cases of ill health, which leads to one of the deepest transformations that have occurred since Alma Ata: the shift in the experience of disease. No longer a succession of discrete episodes, from which the patient either recovers or dies, but increasingly a condition of life. Most people today are not merely sick, they live with a disease. It is a part of their identities, often stigmatized. On the positive side, the context of health systems is being reshaped by 6 revolutions. In life sciences, generating diagnostic, preventive, and therapeutic tools better suited to resource-constrained settings. In telecommunications, expanding coverage to underserved populations. In information technology, potentially empowering people to be co-producers of their own health by enabling access to knowledge, although also to misinformation. In data science, allowing unprecedented capacity to process large volumes of information, a lot of it in real time, regarding physiological variables, environmental risks, and health system transactions. Closely related is the AI revolution. And last but not least, there is what Michael Ignatieff has called the rights revolution, which is turning abstract declarations into concrete entitlements that persons can be empowered to demand. Reinventing PHC requires taking into account these new realities and offering alternatives. An especially attractive one is the emerging trend towards integrated primary health care. The word integrated refers to 2 key dimensions: integration among interventions, particularly where there is a collection of distinct vertical programs, and integration of PHC with the rest of the health system. In both of these dimensions, we can find a window of opportunity to strengthen health systems. To do this, we need to expand our view on health systems and enrich the contents of PHC. Health systems should be seen not only in terms of their component elements, but most importantly, in terms of their interrelations. In a dynamic view, health systems constitute a set of structured relationships between institutions and populations. It is common to analyze only the supply or institutional side of health systems. However, the population is not an external beneficiary of the system. It is an essential part of it. Individuals and families play crucial roles, certainly as patients requiring care, but also as consumers with expectations about the way in which they will be treated. As financiers, through taxes, insurance, premiums, and out-of-pocket payments. As citizens who may demand access to care as a right, information on public health issues, and accountability from public health providers and officials. And indeed, as co-producers of health through therapeutic compliance and health-promoting behaviors. This relational view of the health system is crucial for PHC. Indeed, Alma-Ata proposed a redefinition of such relationship by emphasizing community participation. More broadly, the renewal of PHC should promote major shifts in the relationship between providers and populations. Instead of being reactive to demand, providers should be proactive to health needs by anticipating risks in defined populations. This is the main difference between the narrow view of first contact services and the broader perspective on PHC. In light of the new epidemiological realities discussed earlier, PHC must also take the leap from episodic to continuous care, going beyond the simplicity implied in the original notion of first level of care. The institutional side of the health system also requires new thinking. Among other things, we need to expand our view regarding the functions that a health system must perform. PHC has been concerned mainly with the direct delivery of clinical and public health services. This is an essential function, but in order to provide these services, health systems must perform other enabling functions, such as stewardship, financing, and resource generation. An essential element of health system strengthening is to better enable ministries of health to perform their stewardship role. It is impossible for PHC to articulate intersectoral interventions that affect the social determinants of health at the local level without the broader regulatory and convening capacity of the ministry to promote healthy policies. The financing function is probably the one that has changed the most since Alma Ata, which was very conservative in this regard. In addition to mobilizing more resources for health, 3 financial innovations are needed to adapt PHC to the new times. First, it is necessary to guarantee protection against the financial consequences of disease. Therefore, risks must be aggregated in insurance pools in order to protect families from poverty shocks caused by health events. Second, it is necessary to change incentives for providers. Integrated PHC must introduce innovations in payment mechanisms that reward high quality and responsiveness to the legitimate expectations of the population. Third, it is necessary to make entitlements explicit through packages of essential health services to empower people to exercise the right to health care, thus giving concrete meaning to the aspiration expressed so forcefully in the Alma Ata Declaration. Finally, we have the resource generation function of the health system. Here, the greatest challenge for integrated PHC is human resource development. As explained before, the health system functions of stewardship, finance, and resource generation enable the provision of services, which is the essence of PHC. In this respect, the efforts to reinvent PHC can benefit from the 6 revolutions mentioned earlier and the convergence of transformative technologies. In particular, the telecommunications revolution is mobilizing cutting-edge innovations that are now available even in the poorest communities, such as mobile phones. Appropriate technology should no longer be identified with primitive tools. Today, a patient may be diagnosed and treated in the first level of care in a rural community, but be treated by a provider working in a high specialty hospital of an urban center. To realize such opportunities, it will be essential to increase infrastructure investments to close the digital divide among and within countries. But I am not a blind technophile. The deployment of technology is always contingent on the organizational and societal context in which it occurs. To ensure that it is appropriate, health systems will have to develop effective regulatory and ethical frameworks, most of which will require global harmonization. If we make a concerted effort in this direction, we will have a unique opportunity to strengthen health systems in a way that redesigns primary health care so it is no longer confused with primitive care, but instead becomes the integrative hub of a health system that is anticipatory rather than reactive, continuous rather than episodic, and networked rather than fragmented. In this new context, health for all will finally become an achievable goal in the 21st century.